Okay, can everyone hear me? Hopefully I'm not still muted. For those of you who don't know me, I'm Ainsley Bloomer. I'm one of the ortho PGY2s. Thanks everyone for being here today. I will present on when is frail too frail. Our theme of today is those above 65. And use of frailty scores in adult spinal deformity for preoperative evaluation. I have no relevant disclosures to this talk. So what happens as we age? We have an increasing life expectancy in our patient population now, and the percentage of those greater than 65 is expected to nearly double from 2019 to 2050. We have increasing quality of life demands that come with this as well, and nearly a third of elective surgeries performed are in older adults, as in those above 65. Older adults, unfortunately, also have higher rates of postoperative complications, readmission, mortality, longer length of stay, and are more frequently discharged to post-acute care facilities. But additionally, patients can be physiologically older than their chronological age, so just using 65 as an older adult is probably not the best cutoff. And then aging leads to an increased amount of cytokine expression. We have a pro-inflammatory state. This leads us to increased risk of complications, DVT, PE, as well as worsened postoperative pain, muscle loss, and fatigue. Older adults are more likely to suffer from premorbid conditions, and one of the most important ones is polypharmacy, as this increases risk of mortality, drug-drug interactions, and postoperative complications. So some things we worry about, a little shock and awe factor, but infection, both superficial and deep, DVT, PE, pneumonia, stroke, and death. And importantly, something that can't really be classified in the picture is quality of life changes and functional outcomes that can occur following operative intervention. And how do we define this patient population? Who do we need to worry about? How do we define the elderly and those with comorbid conditions? What does it mean to be frail? Where do we draw the line? When is the risk too high for complications, for example, in planning a spinal deformity correction? And how do we balance quality of life goals with the potential risk of worsening outcomes postoperatively? What systems do we have for our patients here at Atrium, and where can we improve? So to wet everyone's whistle, we'll start with a few cases, but this is a 73-year-old male, severe back pain, bilateral leg pain. He has worsening back pain. He has a forward stooped gait, and new use of a walker. His past medical history is significant for chronic back pain, BPH, diagnosed with depression and anxiety. He had a prior L3, L5 posterior instrumentation infusion, but he is independent with his ADLs and needs some assistance in his IADLs. We have a 75-year-old female, severe back pain, bilateral leg pain. She has a significant past medical history of diabetes, hypertension, prior DVT and PE on warfarin, depression. She does have osteoporosis on treatment, a prior CVA. She previously underwent L2 to L5 laminectomy with significant complication of infection, for which she required hospital stay and IV antibiotics, but this was at an outside hospital, so I don't have the specific details on this. She is independent in her ADLs and IDLs. Last case is a 66-year-old male. He has low back pain. Pain with movement has been progressing. He has also a significant past medical history of CKD, hypertension, OSA, GERD, mild cognitive impairment, obesity, BPH. He is seen by a chronic pain management clinic on chronic opioids and muscle relaxers. He had significant prior spinal surgery, but he's independent in his ADLs and IDLs. So we've seen 3 different patients, multiple different comorbidities. This paper came out in 2022 as kind of an overview of the options we have, a recommendation for seeing patients in a preoperative clinic to optimize them before surgery. So their general recommendations are your traditional cardiopulmonary screening, a comprehensive geriatric assessment, and they use the mini-COG, the PHQ-2, the frail non-disabled survey, and the clinical frailty scale, which I'll go into a little bit in detail on frailty scales, but they recommend an online polypharmacy assessment, targeted rehabilitation, prehabilitation, and medication management, and structured goals of care discussion. This is an example of our assessment from our geriatrics team here at Atrium. This is just screenshots from an example note of things they use. They do functional status, physical performance, frailty assessment. They use the clinical frailty scale, which I'll review. They use cognitive delirium screening, the Charleston Comorbidity Index, depression, anxiety screening, as well as nutritional screening, and then they give a risk for discharge to a nursing facility. The geriatric team's inpatient uses the frail scale, which is a mnemonic standing for fatigue, resistance, ambulation, illness, and loss of weight. So their difference of what they will use inpatient for preoperative evaluation versus outpatient is obviously significant. And then these are just examples. This is by no means an exhaustive list. It could go on forever, but a few examples of different frailty scales, which I'll talk about. It's important when talking about comorbidities and frailty to mention the Charlson Comorbidity Index. It's kind of the initial one. It's cited across all specialties. It was originally started as a weighted index to predict risk of death 1 year after hospitalization in patients with specific comorbidities. It was unique that it used ICD-10 codes because it objectified the evaluations. It originally started with 19 codes, and then they modified it in 1992 to 17 codes. But it is now honestly used more for predictive long-term outcomes. So think 10-year outcomes. And these are the original 19 comorbidities listed, all of which we probably recognize and think about regularly. The clinical frailty scale is most commonly used, it seems, in our system. It is a I don't know where we lost everyone, but we're going to start from here. So they proved that 5 factors is just as equally effective at predicting outcomes as 11 factors, so why not simplify? These are the 5 factors: diabetes, CHF, hypertension requiring medication, history of COPD or pneumonia, and non-independent functional status, partial or complete. And there's many good studies out there. I'll just kind of highlight 2, but this is a study in 2019 that again compared the 5 and 11 factor modified frailty index. They had 281 consecutive adult spinal deformity cases, and they classified these patients kind of as robust, pre-frail, or frail. And of those 281, 22% or 63 patients had a severe adverse event, which is pretty significant. And they said frailty was associated with increased total complications, perioperative complications, implant-related complications, and adverse events. As the index increased your score from 0 to 2, the rate of adverse events increased from 17 to 63%. This was statistically significant. Additionally, they looked at 30-day postoperative complications and readmissions in patients with adult spinal deformity. This is from the NISQIP database, so they got over 2,000 patients. They used CPT codes for greater than 7-level fusion or less. And interestingly enough, they excluded scores of 4 or 5, given that they were only less than 20 patients out of these 2,000. But they still showed that a score of 1 or 2, when compared to 0, had increased rates of 30-day postoperative outcome or postoperative complications. They showed pneumonia, unplanned postoperative ventilation greater than 48 hours, UTIs, and a score of 1 was an independent predictor of 30-day reoperations. A score of 2 was an independent predictor of overall 30-day readmission. So we'll come back to our cases and kind of highlight some of these scores. So this 73-year-old male, he underwent a T10 to L3 and L5 to S1 decompression, T-lift, L2 PSO, and a T5 to ilium instrumentation. He lost 2,300 cc's, had a 7-day length of stay. He had a small durotomy, urinary retention requiring Foley replacement, and void trials at rehab. He did go to rehab for 15 days. He has followed up 4 weeks later. Is wheelchair dependent, still on opioids, 5 out of 10 pain, but from the notes, sounds like he's doing great. His modified factor index score and clinical frailty and comorbidity is listed below, but I'll go over all these for each of them after review. So 75-year-old female, she underwent a redo L2 to S1 decompression, posterior column osteotomies, L2 to S1, T-lift, L2 to S1 instrumentation. EBL was 500, length of stay was 61 days. She unfortunately hasn't done very well. She had significant in-hospital comorbidity requiring ICU stay for intubation, new onset AFib requiring, and then trach and peg. She's gone back to the OR a few times, and she's still in an LTAC. And then a 66-year-old male, he had a T12 to pelvis revision, instrumentation, infusion, bilateral T-lifts. He lost 1,500 cc's. His length of stay in the hospital was 6 days. He had a small durotomy that was not visualized and not directly repaired, but he was discharged home and but has yet to follow up. So how did these 3 patients compare with their frailty scores? So we'll start with our last case. He honestly had the best outcomes objectively and subjectively, but his scores for his modified frailty index 5 was 1. His clinical frailty was 4, which means he's classified as living with very mild frailty, and his CCI is 3. Next, we had our first patient. His modified frailty index was also 5 because he was not fully independent. Clinical frailty was 5, CCI was 3. And then our last patient, her modified was 2 out of 5. Her clinical frailty was actually the best of all of them, 3. She was managing well prior to surgery. And then her Charleston was 5. So although this kind of seems like a black box, we put in, I've given you a lot of information. We kind of still have no results. I think it is better classified as a rabbit hole. We're still trying to figure out where we're going. There's a lot of data out there. We haven't really come to a conclusion. I had the opportunity to talk to some of our internal medicine and geriatric colleagues about this because they're kind of doing the brunt of this work, of this work. And they, Dr. McCutcheon is one of our preoperative attendings who does a lot of inpatient stuff. And she kind of gave me this good overview based on that review article I presented at the beginning, but things to do whenever seeing these types of patients and kind of their thought process are check pharmacy medication list. We worry highly about polypharmacy. Preoperative cardiac and respiratory outpatient therapy is indicated. Nutrition, very important if you feel like they're nutritionally poor. Referral to dietitian, start on protein shakes. Osteoporosis identification and management, cognitive impairment evaluation, functional dependence, maybe need PT or OT evaluation. And then more of the less concrete evaluations, but just as important. So what is their assessment that they're going to discharge to an intermediate care facility? What's their social support, goals of care, and competency discussions, and then identifying a designated surrogate for if something does go wrong. And I would definitely be remiss. I've already talked about this. Last week was Osteoporosis Day, but we can't, as an orthopedic resident, can't give a talk about frailty without osteoporosis. So it's reported as an under-recognized and undertreated in adult spinal deformity. There's a lot of overlap, especially in the literature, of adult spinal deformity and arthroplasty, because these are kind of similar patient populations with similar comorbidities. And then you could give a whole grand rounds on how best to evaluate osteoporosis. But this was a expert review article or expert level 5 evidence article from January of 2021. It was a multidisciplinary panel, 18 experts, including ortho, neuro, endocrine, and rheumatology. And their evaluation was that bone health should always be considered. All patients over 65 and those under 65 with significant risk factors should undergo formal bone evaluation. They recommended a DEXA scan of the hip, given its wide availability, and then medical treatment. Those defined as a T-score less than -2.5 is recommended prior to surgery, and 89% of these experts agreed. So I'm giving a lot of information. What's kind of our takeaway? What's the conclusion? A state of frailty is highly predictive of postoperative complications, readmission, reoperation, and increased length of stay. Tackling this requires a multifactorial, multifaceted approach, including both functional status and medical comorbidities. We need to involve internal medicine plus or minus geriatrics team early. The gold standard is a comprehensive geriatric assessment, but this obviously takes multiple disciplines and extended visits to complete, and it's not always a possibility. And then consider incorporating, as a surgeon, in our preoperative screening and clearance frailty scores. But the bottom line that almost everyone I've talked to about this has said is if you think a patient is frail, they likely are, and they need some sort of preoperative evaluation or optimization. And orthopedics and neurosurgery is obviously not the only one thinking about this, but there's pretty recent studies in almost all specialties, including emergency general surgery, CT surgery, colectomy, esophagectomy, evaluating how much this can help us by preoperatively optimizing our patients, but it is a cost saver on top of improving patient care. So some future endeavors to consider, obviously more work needs to be done. And then clarification of the resources that are available preoperatively, intraoperatively, and postoperatively to help improve patient care, decrease complications, lengths of stay, costs, and consider implementing a comprehensive geriatric pathway. This tool is actually a multidisciplinary tool sponsored by the American Geriatric Society, and geriatrics would love to get this set up in Atrium. For an example, we have our orthopedic fragility fracture pathway that we use at Maine, so it brings in both orthopedics and internal medicine at the same time at time of consult to help preoperatively evaluate and optimize our patients. And then Atrium and Waker are working on a validated electronic frailty index that will be embedded in Epic to help screen for patients that need more than internal medicine evaluation, because for us, geriatrics is a limited resource. So how best to use that limited resource. These are my references. I want to give a special thanks to Dr. Kim and Dr. Kwan from a surgeon standpoint. Dr. McCutcheon is an internal medicine physician that kind of helped me think through this problem. Dr. Capario and Dr. Wood are geriatric physicians. And then Dr. Dango and Dr. Wally helped me think of it from an anesthesia and public health standpoint. Thanks to my class, and I'll take any questions. Sorry, that went off fast. This is 7:32.
Ainsley, it was a fantastic talk, much like Dr. Reese, taking on a really big topic with a lot of different directions, but I think you did a great job of keeping that very focused. So when I started in practice, Dr. Hanley talked to me because I had all these people with, the little old lady with really curvy spine show up. And his advice was, you read all these papers about complication rates. They all have a 300% complication rate. Every patient is guaranteed 3 complications. You just don't know which 3 they're going to have yet. Mm-hmm. And I think that plays out. You've had plenty of complications in those patients. I think frailty, looking at trying to figure out what we can to predict these things. This is where some of the technology we have, like machine learning and AI, to help decide on these patients is probably going to be a great thing for us in terms of choosing the right patients to operate on. I'd certainly be interested in Dr. Kwan's comments on this as well, because it's just such a, like you said, such a black box. You look at these data and that's sort of helpful, but sometimes not. And you can really make people worse. So I guess my question really is to both of you is, when do we say no to these patients? I think you have a patient who is having functional decline from clear myelopathy, severe stenosis. Those are neurologic things that we can probably make better with spine surgery most of the time. But if this is severe back pain with a very curved spine, which, we like to say we don't operate on that, but the truth is those are a lot of the operations, is a very significant axial pain component in these very degenerative spines. And there's inefficiency of walking with some of them. So I get it. It's not just axial pain, but, did you learn anything? Do you know any better how to pick now?
No. That's the official answer is no. I mean, like the case that you showed, there's no kind of correlation between frailty and how they did. I think probably the best comment is just they appear frail, they probably are. So I think the threshold to not operate on someone has definitely been pretty low as of late. So I think the more you do these cases, the more you see these complications, and maybe not, it hasn't been so scientific, at least for myself, but once you kind of go through these patients who've been in the ICU for 3 weeks, or just you see it every time they show up, there's like another complication on another, I think you kind of get a little bit gun shy with some of these patients. So, I think, you kind of divide these characteristics or categories in terms of addressable qualities and non-addressable. So if someone has hypertension that's, reasonably controlled, I don't know if there's a whole lot that I can do about that, or if they have, CHF that's been somewhat optimized, what's good CHF versus bad CHF. But I think the things like osteoporosis, I think, are kind of hard numbers where I do the same thing. I test them all. If they're less than 2.5, we're delaying their surgery. We send them to get that part addressed. If someone's diabetic, you have control over that. And I think you kind of figure out things that you actually have direct control over. My question is, as far as going through all this information, we talk about these scores and whatnot, but, have you seen anything that maybe directs you in terms of doing like a bigger or smaller surgery? So you have someone that's frail who needs potentially surgery. Is there data to show that that person can maybe tolerate smaller surgery that's more preferable versus someone who can handle a big, T2 to pelvis or T4 to pelvis?
Yeah, I didn't find any specific data. I think it's more that multidisciplinary approach. Dr. McCutcheon kind of talked about how it's her preference, if she's seeing these patients, to evaluate them independently and then call and talk to the surgeon and say, what are you planning to do? What are our options? Like, I think they could withstand probably this much, but if you're going to take 6 hours and their blood loss is going to be, more than a liter or something like that, that's probably not the best thing for them. And again, I think most of this is gestalt based on experts and what they've seen and pattern recognition, but I didn't find any specific good data that evaluates it.
Ainsley, good job on your presentation, big topic. Obviously, as a part of the Own the Bone initiative, this is a big focus for all of orthopedics. I know you're approaching it from a spine perspective, which is your interest, but really impacts every subspecialty within ortho. You also mentioned the relationship with Wake Forest, and they're a little bit ahead of us on this, but we also have our own initiative on fragility here, working Matt of Geriatric leading that with some APPs. But do you have some recommendations for us of how we access that system if we have a patient that's of concern and we want some help with it? What's our programming here? Maybe this was discussed last week. I missed the presentation, but can you go over that for folks that may have missed that?
Yeah, so we have internal medicine who will see anyone and evaluate them. And then on top of that, geriatrics. They are a more limited resource. So that's where this electronic index should help some to indicate who should be evaluated by geriatrics. After talking to them, their recommendation is the second you have a concern, or even if you have a concern, if you have a patient with significant medication list, to just involve them on the front end. So the second they get out of the OR, or if you know in advance, they want to be involved from the get-go, because it can help prevent postoperative delirium and limit length of stay and complications. And then at least from our standpoint, IM will kind of tag in geriatrics for if they have additional concern and need additional assistance. That's currently our system. I've talked to spine attendings elsewhere who actually have different systems where they get geriatrics involved preoperatively, and the same team will follow them in the hospital and then postoperatively. So there's different systems, and I think speaking to the geriatric physicians, ours is evolving, but currently the best recommendation is to involve internal medicine. Or you can send them to geriatrics preoperatively, and they'll do a full assessment. Dr. Kim?
That's a great talk. And we're all seeing this in medicine and certainly in our fields where the general population is aging, and it creates challenges because 20 years ago these patients were no-go. They were off limits for spine surgery, and now with patients living longer, being healthier, and then we have more data, we have more technology to be able to do better surgery, more complicated surgery, safer. It just creates more dilemmas in patient selection. So. Of all the things that you talked about, and they're on point. One of the things that we look at, though, as you pointed out, was how can we, if we decide patients, as Dr. Moore was saying, they look like they might be cancer surgery, then how do you optimize them? And so, to that end, we've learned from the hip and knee folks, how do you develop ERAS protocols to try to optimize patients for surgery? So if you're going to choose a patient, you think they're good enough, well, how do you tee them up to get them in the best condition? And surgeons and docs have made careers out of talking about ERAS protocols in frailty and disease, but as you pointed out, we don't really know what the impact that is. But I think we're an exciting point here of all the data collection that we're doing, and then being able to look at all these different parameters for pre-op optimization within the patients that we take care of the system, and having a real strong and robust outcomes, section to be able now to correlate what improvements are we making preoperatively, how does it correlate to how people do afterwards, and that really hasn't been demonstrated so far. So we looked, here within this system to be able to generate some data and publish that to that end, and maybe it does correlate patients that might do better with a smaller amount of surgery versus a larger amount in terms of what their outcome is, both in the short term and long run. But this is a really complicated topic. I mean, there's symposiums that are, as I told you, that are based on this, and you've been able to condense this in a short period of time for us.
I think the key to add on to what you just said is that if you look at your original box of contributors to frailty, very few of those factors are truly modifiable. We can optimize them, but we can't get rid of somebody's med list. We can't get rid of their CHF. But osteoporosis is probably one that we can, and everybody talks about treating them. So I think what Dr. Mormon's question, both here in the Northeast, we now have bone health program. J.C. Holzinger kind of leads it here. Luke Harmer up at Northeast. So we can send those people to them. But Paul, Al, Tony, how do we know when is enough? Like a month of treatment, 6 months of treatment? Does their T-score go from -2.5 to -1.5 and then they're okay? Like that is one of the things that is probably modifiable, but what is the number? is it just, oh, they've been treated for a few months, now we're good to go?
I mean, it depends on the degree. So if someone is like minus like 3.5 or just something, I think that's, no matter what kind of treatment, they're probably on the no surgery list. If someone's kind of a -2.7 or whatnot, then I mean, my general rule of thumb has been 6 months of treatment, but I don't retest them to see if it's increased.
Well, there's not good data to say that retesting in 6 months changes.
So, for me, it's like if they're close and they get treated, 6 months tends to be, but it's based on no science or data, just makes me feel better.
I don't, same thing. If they're -3, so no go for sure. And that was a question. Did anybody look at life expectancy, the operative versus the non-operative groups, or correlating with the fragility score? Did anybody look at the cost to the system with these patients?
Yeah, so I'm not sure about the comparative group to non-operative controls. That's a really good question. I can definitely look into it and get back to you. But they have looked at cost, and sorry, my PowerPoint is now down, but there's actually a lot of good studies about cost improvement for preoperative optimization in these patients and how much it increases cost, because some of the biggest expense often is just staying a night in the hospital, whether it's just delirium. And then if they have to go to the ICU, that's obviously exponentially increased. So yeah, it's definitely improved cost. I mean, it's very much cheaper to get PT outpatient to make you stronger than staying in the hospital and getting physical therapy and going to acute rehab after because you're just not strong enough.
It's a great talk. Obviously, it's focused on patient care, but just a question probably better for the attendings. Is there a way that you found, either a modifier, I know you can probably bill them a level 5, but to get compensated for this work? Obviously, this is a ton of extra work to coordinate with geriatrics and, really keep up with these patients. But, I think a lot of these people fall through the cracks because you're just.
Yeah, I think the answer is no, like you can't really get compensated.
This is a labor of love.
Yeah, so it's just outcomes, but we're like pretty simple people. We're just trying to put screws in bones.
Yeah.
The last thing you want to do is to do all that. So for me, if it's going to be a level 4 versus level 5, like that's of the least interest. I'd rather just push it off to someone, let them kind of manage it, which is where I think that multidisciplinary approach is the right way. Because if like Paul's the one making decisions on osteoporosis or CHF, he's probably the wrong person to be doing that. So we want to get him to like the experts, get him to the pros. We'll focus on like the architecture and the carpentry. They can focus on like all the other issues. But I think for me, that's been my approach. Is if I see some of those red flags, like they're going to go to the experts.
Yeah, obviously we're not going to do that. I just meant like to actually send them there and have that discussion. I mean, that takes longer than.
Yeah, I think it is, but I think like if the system is in support of that and it makes it easy to make that referral, or they have a system in place, I think that makes it much easier. It's a click of a button versus if you're in a smaller community and you have to coordinate finding geriatric doctor, finding someone who deals with osteoporosis, finding someone who is an endocrinologist. I think like we're lucky in this town in the sense that it really is working by referral.
So Nick, just to finish up, and then we'll let Ainsley off the hot seat. There actually is a good answer to that question for all these patients, for all the complicated patients we take care of in the hospital. So you can be, sort of get lower scores as a surgeon in your patient selection, and the hospital can actually get penalties if you don't adequately punch in all those diagnostic codes. So that CHF, it seems like silly, we're not going to manage it, but we should put those codes in because it increases the complexity of the patient. So they actually, if you have a readmission in a patient who is highly medically complex, it counts against you less. So there is some indirect benefit to that, especially, from Dr. Moorman's seat, who sees these penalties that the hospital gets for readmission. That changes significantly when you increase it. And, we joke about why does Gastonia Hospital, I don't know what it's called, Caramont, no, whatever that one's called. Why are they listed as a top cardiac hospital? Because we know cardiac transplants and the sickest of the sickest are coming to CMC. It's because they have low mortality because they're operating on healthier patients. So in order to stratify yourself, so this is not a direct reimbursement, but it is an important thing for everyone to learn how to code these things, because it will, make you look better and can make you a center of excellence.
It's U.S. News and World Report too. If you think about all the best orthopedic hospitals, none of them have ERs. It's HSS, it's Cleveland Clinic, it's Mayo Clinic. They don't have any complications because they're treating well patients. So you got to record the complexity. But in terms of the financial question, I think it's actually a very good one, because when we're thinking about a big program for fragility, how do you fund that? But there's actually a lot of reimbursement in these infusions and other things that the endocrinologists and others are doing. So it can be a financially sustainable program if it's a complete and comprehensive program. That's what we hope to have. Obviously, we're more concerned about the patients, but the system's not necessarily on us. They want to make sure there's an ROI on board.
Good question. We should be teaching all of you about billing because it is important to understand. So great talking to you. Thanks, everybody.